is HIV, AIDS, and pain in general. So I'm just going to do, first of all, a general overview, and then we'll go through it. Just keep in mind the reason why HIV/AIDS patients end up with pain is 60% is the reason is by the viral infection, the immunosuppression the virus itself causes. About 30% is because due to the treatment for the infection, and about 10% is due to other reasons. But just realize that there are reasons why they end up with pain. As we know, this is the retrovirus, going back to micro. The background is, again, it's the retrovirus that contains the enzymes. We know this all. Just realize that comes a part of the DNA, and then there is two related retroviruses, HIV1 and HIV2, which are clinically widespread throughout. The implications is how virulent they are. The HIV1 is mainly found in Europe, Asia, Western Hemisphere, in these areas. The HIV2 is mainly in Western Africa. And there are certain areas in Western Africa that have both as well. The HIV2 is less virulent compared to the one. The endemic is growing and stabilizing at the same time. The biggest factor that's growing is in the heterosexual population and in children. In about 2006, there have been 56,000, a little more than 56,000 people infected newly. Worldwide, there is greater than 40 million people with HIV. There are deaths due to, cirrhosis, cancer, and organ failure that this virus leads to. And the biggest factors that we're seeing the highest risks in women, in African Americans and Hispanic populations due to non-compliance. The basic vulnerability, as we know, this is a general knowledge, when your levels of CD4 levels fall less than 200, then you're predisposed to the opportunistic infections. The diagnosis, of course, as we know, is ELSA, and if that's positive, we go due to the more sensitive one, which is the Western blot. As we know, the prognosis, once you have HIV, you have HIV, and that can develop later on to AIDS. However, it's no longer a prognosis that's a short-lived prognosis anymore with the new treatments and medical care, and if they're compliant, they can live up to 70 to 80. Which I have a couple of 70 to 80-year-old HIV positive patients. Of course, during the longer the life now that they're having, the more tendency of seeing the pain symptoms, complications, and all the rest that comes with the disease itself. The neurological symptoms can be one of the most common presentations. And some of the manifestations can be CNS or peripheral. We have also, you can see dementia related to HIV, CNS manifestations, and PML. 5% of the people with the HIV can develop PML, that's the infection of the brain. I don't need to read all of this, do I? You guys know it all. The other ones are the myelopathies that can occur. It's basically slow progressing, and it can manifest with lower extremity stiffness and weakness, ataxia. The one thing that you have to note is that sometimes a patient will come to you, which happened to me when I first started in the beginning of my practice. A young guy comes in he was about 40, he was very young, well built, no other medical problems, no real thing, but had some kind of numbness, tingling, burning in his feet. That was the only reason why he showed up. And I kept on asking him, because it was unusual. He did not have any predisposing thing to have some kind of a peripheral neuropathy, no diabetes history, nothing. No asthma, no, steroid usage, nothing that I can pinpoint. And I kept on asking him, are you sure you don't have HIV? And he would get really pissed off at me. Then he disappeared. 3 years later, he shows up and he tells me, Doc, you were right. He didn't know that his partner was infected. So, that neuropathy can be one of the clinical manifestations that can occur in the beginning without any signs. So some of the other stuff that we can see in the CNS involvement associated with the HIV patient populations, of course, the dementia, toxoplasmosis, the lymphoma, the encephalitis, and many of them are related to the CD4 counts, and some are not. Of course, this is just a continuation. You could have demyelinating polyneuropathies, you can have myelopathies, you can have leukoencephalopathies, and you can have distal symmetric polyneuropathy. And some of these are basically related to the CD4 count. And these are just some of the other manifestations that are also associated with HIV viruses, HIV virus infected patient population. Now, the onset of the neuropathy can be days to weeks. It could be pain, it could be sensory loss or weakness to moderate. It can be symmetric, it could be asymmetric. It could be related to 83% of the time axonal loss. I think we went through this one. The most common one that we see that are more severe or more complex is when the CD4 counts go down below 100. And that you could see as mononeuropathies. And then the biggest one that we worry about is quad Aquinas syndrome, which is more serious because it can lead to many other problems with facet paraplegia, urinary incontinence, the things that can happen. Now, you also have oral manifestations related. You have thrush, you have leukoplakia. Some are painful, some are not. It can affect the nutritional status. It could, some are, they just might not even realize they have any problems. The other biggest problem is herpes simplex. You can have herpes zoster. Could be very severe and painful with these patients. In fact, I have one when they have an outbreak. It can be very intense, very widespread. And what do we do if they have post-herpetic neuralgia? We could do Quintenza. And it does work. I have one patient who just got approval. I think Friday you might see him. He had an outbreak of zoster in the chest on the left side, basically from the top of the shoulder all the way down to the end of the sternum, and that whole left side is cut. But he does well with Quintenza, which gives him pain-free symptoms for about a year for him. These are the general cardiopulmonary manifestations that can be associated, can be seen. Doesn't mean it's going to be. The main one problem that is seen is the lipodystrophy syndrome, which is seen a lot in the HIV patients, and I'll go through that a little later in the slides, especially associated with certain antiviral medications. The other issue is they can develop diabetes or glucose intolerance, either due to the virus itself or to the treatment that they're receiving. And these are studies that have shown that they also, why they develop it, most closely related to the PI use of protein inhibitor. another one. I'm just going through them. So what is lipodystrophy? It's the redistribution of fat that can accumulate in other areas that normally doesn't occur. And main presentation is a big distended abdomen. It develops on the waistlines and it causes a lot of risk factors. And most important, besides it causing a lot of medical risk factors for diabetes, coronary artery disease, and the psychosocial aspect of having big deposition, like a big beer belly all of a sudden. They're skinny in the arms and the legs and they have this big protruding belly. That is really, they found that it sometimes can be related to the treatment in itself. And the way they do it, they try to do is change the medications, see if that might help reduce it. They found that if you exercise, it might reduce it a little bit. But that is a big problem, and that could also lead to non-compliance of the patients if they're developing. I have a big picture for it. This is a very big issue. When I was going to the clinic over here in Peter Kruger, this is a very big issue. People want to feel skinny, and that skinny is issue, when all of a sudden they're still developing a big stomach and abdomen, and they're thin in the legs and the arms, nowhere else it's depositing. It becomes a big psychological issue for them. There's also hematological disorders. I'm going to spin right through some of these, okay? And as we know, as they progress, they can develop into AIDS, and some of the side effects of some of these medications, ACT, usually cause proximal weakness, lead to pain. All right, I'm just going to go right through. Now, common types of pain. 26% basically develop abdominal pain. There's roughly 25% will develop peripheral neuropathy type of pain. Roughly around 20% you might see throat pain. About 63% can have headaches. Not migraine headaches, but more tension headaches in this population. But what we see right now is more in the clinic is the peripheral neuropathy type of pain. And you don't see more, they don't really come too much with abdominal pain to us, but more, and they come with low back pain. But the peripheral neuropathy, as we know, it's numbness, tingling, and burning. It's the nerve damage caused by not only the virus itself, but the treatment for the virus as well. The abdominal pain is also possible. Again, side effects due to the medication for it, the virus itself, and sometimes people take the virus antivirals and they drink, lead to pancreatitis, lead to inflammatory issues. You know, they develop many side effects. So the abdominal pain is also very commonly seen among them. Headaches. It's more common to have tension type of headaches than migraine type of headaches. It's more of a pressure, throbbing, dull type of headache than your typical migraine. But they can also have to worry about brain issue, involvement of the brain. Do they have stroke? Do they have lymphoma, etc. The other pains are also the joint pains, bone pains, herpes pains we went through. Now the treatment's what's important. Opioid treatment, your regular start from Tylenol down, your narcotic treatments, your topical treatments, our usual gambit of stuff that we offer these patients on the treatments. The problem, and injections, of course. We do injections on the HIV. The one thing I want you to remember, if you're going to inject anybody with steroids, whether you're going to do an epidural, a nerve block, any kind of injection, you should always take into account what their CD4 count is. My general limit for doing any kind of injection is a CD4 count of 400. If they have a CD4 count of 400, I will inject, but if it's any less than 400, I will not, because the risk of infection increases. The risk of causing steroid myopathy increases. Now, these patients are prone to also myopathy. If you steroid inject them 3 in a row, 2 weeks apart, they're fine. But if you do more than that and you don't give a break, you will see myopathy. You can see cushingoid. Their faces will swell up. They will become like a cushingoid appearance. It can happen. So just be aware. Also, the steroid decreases the CD4 count. So let's say they started at 400, or they were a little below, and you ended up injecting them. Every injection can decrease their CD4 count. Just be aware and just document on how you're doing them and how much what you're giving to them, because it has implications. So that's why when I do patients, in fact, you'll see one patient, she's becoming a little bit cushingoid, and so we have to give a break for her. Now, these are the treatments for the general heart therapy that they start. When they start, the general rule of thumb is 500 below. Of course, if they developed any kind of opportunistic infections, even if they have levels that are higher, then they would also be started on antiviral treatments. The treatments that are out there is the NRT ones, which are the generic names and the brand names. These are one of them. Then there is also the non-nucleoside analog reverse transcriptase inhibitors. These are also. Then they have the proteinase inhibitors, which, remember, they can increase lipids within 48 weeks. These are very commonly associated with the lipodystrophy syndrome. Then a lot of people end up with dual therapy, triple therapy. Remember, the regime itself is very hard to swallow. A lot of patients who take these medications have a lot of GI upset. They have a lot of nausea associated with them as well. It's cumbersome for them. Some just don't want to take it. And of course, the toxicities with the neural side effects of these medications, we went through them all before. The most important is that they can end up leading to the peripheral neuropathy, the abdominal pain, the low back pain that will end up at your door. But just remember why they have the pain. It's not because of anything else, but they truly have reasons to have the pain. Because of these medications and the medical care, they're living longer. And then we're seeing the side effects and complications of them living longer. And that's a very common presentation of a lipodystrophy. It's thin and they have the protruding abdomen. Of course, there's new treatments coming out for them, and also a vaccine has been just approved for human trials. I don't know who's going to do that, but it's been there. Just remember, once they have HIV, they will have HIV for the rest of their lives. They can lead into AIDS, and that's because of the HIV, the virus itself. As I said, 60% will develop pain because of the virus. 30% will develop pain issues due to the treatment. Then there's 10% for other reasons. Any questions? It's a quick overview. Back to school. Let's go back to school. All right, sickle cell. As we know, it's a genetic disorder. If we didn't know by now, it's common among, in the United States, about 75,000 are infected. It probably is more by now. It's, as we know, is a result of a mutation of the beta globin. And it's most common in 8 to 10% in the African American population is a sickle cell trait, and about 0.03% to 0.15% have the sickle cell anemia. 50% of those with the sickle cell anemia die before the age of 20, and most of the others can live all the way up to 40. But remember, sickle cell anemia is also common in parts of Africa, in Spanish-speaking areas like South America, Cuba, the Caribbean, Central America, Saudi Arabia, India, in the Mediterranean like Turkey, Greece, and Italy. So it's not just a confinement to the African American population, it is seen in worldwide areas as well. It's, as we know, the trait is the recessive when you have both SS, and the disease is at the SS and the trait is the AS. So basically, if they have the trait and they end up in the emergency room saying they have a crisis but they have a trait, suspect. Because they usually don't have symptoms, okay? They live normal lives. Yes, you offer them the pump and give them some Dilaudid. You make sure you give them lots of Percocet to go home with. Make sure you have the Percocet to go home with. Okay, but the anemia ones now with good treatments can live for a while. And they can have a fairly healthy life. They can live up to 40 to 50 years, some of them longer. Unfortunately, I had a sickle cell anemia patient who died around, he was about 32. But he lived okay up to 32. But it is a deadly illness, but it's the ones with the full-blown recessive trait. The anemia, not the AS, but the SS ones. The ones with the trait do not have these issues. The one with the anemia have the issues. So basically, our basic principle, they should avoid dehydration, they should avoid high altitudes, they should avoid stress situations. They should avoid going to the emergency room. That's the key. If they could come to the medical doctor or to their pain doctor or whoever, they should get better care as an outpatient and a steadier care that way than ending up in the emergency constantly. However, saying that, they do end up in the emergency room a lot. Okay. So basically, what happens in the sickle cells? We have increase in viscosity, you have reduced blood flow, you have vascular occlusions can occur, and therefore leads to even more sickling. So hydration is very important with these patients. They should all, of course, be constantly drinking, and especially in hot weather in the summer, they should not, avoid being so sweaty. They should constantly be drinking. The signs, of course, is the typical pain crisis, and they have the acute chest pain syndrome, the vascular accidents that occur, the chronic anemia, the infections. All these are symptoms that can happen, and most of them end up with renal dysfunction because the kidneys start to fail because of occlusions that do occur. They end up with leg ulcers, organomegaly, cardiac failures, and of course abdominal and bone pains, and they can end up with aseptic necrosis as well. These are the further on. The basic types of pains they do present with is nociceptive pain, and then neuropathic pain also. So they can have reasons for pain that are periodic. And remember one thing, pain occurs because of blocked blood and low oxygen. And it's a painful event. Crisis can occur any part of the body. That crisis could happen in the abdomen, they end up with abdominal pain. It can happen in the bone, they'll have bony pain. It can happen in the arm, anywhere in the body. There are patients who will have less than once a year crisis. There are ones who will end up 15 or more crises per year. The crisis is usually acute, sudden, it'll happen quickly, and they could have ones that are chronic, or a mixture. The acute form is mild to very severe, and it can last from hours to days. If they have complications or they're not really treated properly, it can last for weeks. The chronic form is something that lasts for about 3 to 6 months or longer, which can cause severe limitations in their activity levels, and some people just have a combination of both. The severity of the disease you can look it up as laboratory findings with decreased hemoglobin, decreased hemoglobin F, the increased hematocrit, the increased white blood cells, and all the complications can be related to all of these findings. Now managing, that's what you want to know. Managing the crisis. High doses of folic acid, as we know, analgesia for the pain, and hydration. The biggest thing is if they're going to have general anesthesia, they should not have general anesthesia if they have a hemoglobin below 10. They should also worry about nitrous oxide exposure. They should avoid barbiturates. Should really avoid strong narcotics, but they don't. So, value. But seeing all of this in mind, if the way to prevent them from going to the emergency room constantly and really to reduce their level of crises is really getting them on some of these patients on a long-acting. And long-acting, if they have good pain control all the time, they tend not to go to the emergency rooms. They tend to have less crises. They tend to do better than ending up in the emergency room getting IVPCs or getting constant medication, or coming into the hospital as an inpatient for a couple of days and getting the same thing and going out again. So remember, salicylates should be avoided with these patients if they're in a crisis because of the acidic effect. Opioids can be helpful, and Dr. Shayova did a couple of studies, and she was big into the study of pain with sickle cell disease anemia patients, and finding that if you can give them continuous long-acting opioids, mainly fentanyl patches, that you can reduce their number of crises, and you can reduce the number of visits to the emergency room. Therefore, they can have a little more productive lifespan, a little productive life, and maintain a job instead of constantly being in the hospital. We're done.